Hello, I'm Dr. Daniel Ginn with Minimally Invasive Gynecologic Surgery in the Department of Obstetrics and Gynecology at UCLA. We're going to talk about endometriosis. I have no financial disclosures for this talk. Our objectives are to understand some basic physiology about endometriosis, review symptoms and physical effects of the disease, and then explore treatment options with medical and surgical management, as well as some resources for patients. So let's start at the very beginning. A basic definition of endometriosis is viable estrogen-sensitive tissue, endometrial-like glands that are found outside of the uterus. These are involving the peritoneum, the other organs potentially around the pelvis, where they're not supposed to be. This is a chronic inflammatory disorder. We know that there are some molecular level differences from these tissue samples and endometrial tissue that's from the endometrium of the normal uterus itself. So it's distinctly different from that on a molecular level. And clinical diagnosis ultimately is only confirmed with a biopsy. There's some different theories about how do you get endometriosis? Where does it come from? The oldest one is this one about retrograde menstruation. The fact is, though, retrograde menstruation is a common phenomenon. And what that means is during a period, blood goes out through the tubes instead of out through the cervix and vagina. Well, if we saw that in everybody, then we should see endometriosis in everybody, but we don't. And so there's a question of maybe this is some inherent dysfunction of the immune system in the peritoneum itself. There's another, it's called coelomic metaplasia, and that's a fancy version of just saying that some of the cells that line the peritoneum, which is the stretchy covering of the cavity of the abdomen itself, change into the wrong kind of tissue. Another is malarianosis. This is one that is present during fetal development, where tissue that's not supposed to be outside of the uterus implants there and then grows. There's also theories that involved hematologic, meaning through the blood, or lymphatic, through the lymphatic system spread through other areas. And that might account for why we see some endometriosis in places outside of the abdomen and pelvis itself. The symptoms are important. So the most common symptoms are adnexal masses. Adnexa is the side of the pelvis itself, so just a pelvic mass. Infertility, dysmenorrhea is the medical word for painful periods. Non-menstrual abdominal and pelvic pain, dyspareunia, which is pain with sex, bowel symptoms like nausea and vomiting, those kind, and dyschezia, which is painful bowel movements, as well as painful bladder, and dysuria, which is painful urination. These are a lot of easily confused symptoms, though, and they can be easily confused for other diagnoses. So just benign ovarian cysts that are from the cycle themselves, maybe physiologic. Adenomyosis, which is a similar condition to endometriosis, where these cells, instead of growing outside of the abdomen, have grown up into the muscle layer of the uterus itself. Irritable bowel syndrome, adhesions, neuropathic or nerve pain can all present similarly to endometriosis also. Pelvic floor disorders are very important. These are disorders of the musculature of the bottom of the pelvis itself, and this can present as a chronic pain disorder also. Hemorrhoids, interstitial cystitis, which affects the bladder, and anal fissures can all also cause pelvic pain that can be diagnosed incorrectly or confused for endometriosis. Risk factors are also kind of a challenge. Early menarche means people who started having a period earlier than average. Women who have shortened menstrual length, who have heavy menstrual periods. Nulliparity is when someone has never had a pregnancy before. Family history also seems to give us some indication of a risk factor. People who have a first-degree relative, so that would be like mom or sisters, have 7 to 10 times the risk of having endometriosis as people with no family history. And then when we do gene studies, they see abnormalities that involve some specific numbers of genes, and the more of them you see, the higher the risk of severe disease is as well. So why does this really matter? Author Abby Norman wrote a memoir about her experience with endometriosis. She said, as patients, we're asked to rate our pain on a scale of 1 to 10. Yet as any woman who's experienced illness, chronic pain, endometriosis, or childbirth can attest, even if you report a level 10, you'll have to fight hard to have your pain taken seriously. Endometriosis affects 6 to 10% of reproductive age women. The average age of diagnosis is 28 years old. Sometimes we think the reason that the average age of diagnosis is actually so late is not because that's when someone became symptomatic, but it's instead because it can take 7 to 9 years to get to a diagnosis on account of trying other things first. The rate in transmasculine patients is unknown. The financial impacts are enormous. In the United States alone, it's estimated to have an impact of up to $49 billion a year. That's through surgery, through loss of productivity. Many people with endometriosis miss work, miss school because of their symptoms on a regular basis. The physical damage is probably the worst part. Pain, the progressive nature of the damage itself. Endometriomas, which are cysts on the ovaries that contain endometriosis fluid. Superficial endometriosis that affects the peritoneal cavity itself, and then deeply infiltrating endometriosis, which are implants that go deeper through that tissue and might affect the organs that are underneath. And also extrapelvic endometriosis, which can affect the liver or the lungs or the kidneys. The pain pathways that we understand with endometriosis are pretty intense. There are systemic and also local, we call pro-inflammatory cytokines and growth factors. So basically these are signals that the brain receives both systemically and locally, telling your body or telling your brain that your body is in pain. Long-term exposure to this creates sensitization that then becomes hyperalgesia, and that's where you feel a more intense version of what you're really feeling. Repetitive stimuli like this, repeatedly feeling pain over and over again, can then also lead to chronic inflammation and nerve injury, and also rewire the pain processing that the person experiences. And this can lead to a condition called central sensitization. Central sensitization is, as I describe it, you hit your foot and you hit it again and you hit it again every day. And eventually your foot starts sending signals to your brain that say, I hurt. And then your brain starts sending signals to your foot, even if you're not hitting it, that say, I hurt. And so then we have this altered processing that sometimes is very challenging to correct. Endometriomas are cysts on the ovaries. We call these chocolate cysts more traditionally because, as you see here, the fluid that comes out of one of these looks kind of like chocolate. The theories of why they exist is that they might come from superficial implants on the ovary themselves, or it might be where an implant from a cyst, then metaplasia, like we talked about earlier, turns into the wrong kind of tissue. These are closely linked with ovulation, meaning the more cycles you have, the more likely you are to form one. They can cause intense fibrosis and inflammation, and they can penetrate rather deeply. In this case, we're talking about 1.5 millimeters, which doesn't sound like much, but when you're talking about tissue on a cellular level, that's very deep. These can sometimes be difficult to excise because removal of the cyst itself can actually damage the ovarian reserve. And so we often have to have a discussion about what our real goals are here and whether or not an endometrioma should be removed, especially if someone is dealing with infertility already. On an ultrasound, an endometrioma has a very characteristic appearance. In this slide, you can see here, this is the endometrioma, and it has this snowstorm, we call it, appearance to the middle of it, rather than being all black like the area up here, which would be more characteristic of just surrounding fluid if it was within a cyst itself. Superficial endometriosis, the most common locations are on the ovaries, the pelvic peritoneum, that stretchy covering, affecting the broad ligament, which is the ligament that drapes over the support ligaments of the uterus, and the cul-de-sac, which is the space between the uterus and the rectum. The uterosacral ligaments are the ligaments that also support the uterus to the sacrum, and this is also a most common place for that. And so in this slide, you can see these implants of endometriosis here indicated by the arrows. This is your uterus, this is the ovary, this is the uterosacral ligament on the right, and this is the one on the left here. And then the rectum is down at the bottom. Deep infiltrating endometriosis, sometimes abbreviated DIE, which is a terrible abbreviation, more commonly now DE, is very important. And so in this particular photograph from a surgical case, you see the uterus up here. This white part is an ovary, fallopian tube next to it. And then on the other side, I went a little too far, the other ovary here, and then the rectum down at the bottom. So on this surgical image, you see endometriosis here, right here, and right here. This is your uterus, the rectum is here, ovary and tube on the left side, and the ovary and tube on the right side. What you see in all of these instances is a nodule that can extend greater than 5 millimeters deep. So that's a half a centimeter. Surgically, that's very deep. This can cause fibrosis to the area and a mass effect, meaning that all of these organs become stuck together. And in these cases, we often have to work with our colleagues in colorectal surgery and also urologic surgery, as it might, in this instance, you see, do what we call obliteration of the cul-de-sac. So the cul-de-sac, again, is this space here underneath the uterus, and it should be open, and instead it's completely closed off because of scar tissue from the endo. Urologic surgery sometimes can be necessary because the ureters, which are the tubes that connect the kidneys to the bladder, can also be impacted. They can be fibrosed, they can be compressed, or they can actually have endometriosis invading them as well, and that might require a resection of that area by a specialist. These are some other surgical photographs. On the left, you see the bladder and the uterus are very densely adhered to each other. This area indicated by the arrows should be much smoother than this. On this other photograph on the right, you have a uterus here, and then this is all small bowel or small intestine. None of this is supposed to be stuck together in this way. And so these adhesions are very important to address very carefully, and sometimes to make sure we have a specialist with the bowel surgeon who's available to help. Extrapelvic endometriosis, as I discussed earlier, can be seen really anywhere else. So that could be on the lungs or the kidney. Both are outside the diaphragm. The diaphragm itself is this whole area here. So this is the liver. So I did say earlier that liver could be extrapelvic. It is extrapelvic, it's not extraperitoneal, so it's within the same cavity. But this area of the diaphragm would be more important and of concern. And here I've circled one area that was an endometriosis implant on the diaphragm. Patients who have this disease finding often experience pain with breathing, or we call respiration. Sometimes they notice it if they're exercising, or they have pain that's referred to their shoulder. That's just common with irritation from the diaphragm itself. This particular finding definitely requires a multidisciplinary surgical team to address it. This is just a closer picture. You again see here endometriosis right there on the diaphragm itself. So let's talk for a second about endometriosis and infertility, because this is often the biggest concern and certainly the most alarming one. Someone gets a diagnosis at a young age, or they've been trying to build a family for themselves for a length of time, and ultimately they're told you have endometriosis. Does that mean I can never have a baby? Does that mean I'm going to continue to struggle? Well, the real answer is that we don't understand this relationship that well, other than knowing that it occurs. We think it might be because there's an inflammatory environment that damages the sperm or the oocyte, which is our term for the egg. It can also diminish ovarian reserve itself, so patients who have those endometrioma cysts on the ovaries. It's possible that there can be lower rates of implantation of a fetus or of an embryo to grow into a fetus. And then severe adhesive disease can also cause occlusion of the tubes. So the tubes, if they're not open, you cannot get pregnant through them. There's mixed evidence about this, and the question is, does it cause subfertility, which is just not as good fertility as one had before, infertility, which is a complete inability to become pregnant? It's unclear if deep infiltrating disease makes a difference with this or not. Once someone gets diagnosed with endometriosis, then we talk about staging. It's very important to emphasize at the beginning of this that the stage of disease does not equal the severity of symptoms. Stage 1 disease is mild findings. These are usually small implants that are impacting the peritoneum. They could be on the organs, but they're usually superficial and they cause minimal scar tissue. Stages 2 and 3 are moderate findings, also affect the same areas, and they can also include the ovaries. They have moderate scar tissue. So if someone has an endometrioma cyst on the ovary and that's maybe the only finding, they're going to probably stage out to stage 2 or stage 3. Stage 4 endometriosis is severe findings. These are affecting the peritoneum, often multiple organs. So maybe the bowel, the bladder, the ureter, the ovary itself, or the tubes. These often have severe scar tissue throughout the pelvis. Again, though, it's very important to recognize that the severity of what we find doesn't always correlate to the severity of what someone experiences. One person's stage 1 findings is someone else's stage 4 symptom. Someone else's stage 4 findings is someone else's stage 2 symptoms. In the end, we treat the patient as an individual. How do you make a diagnosis? We start generally with an ultrasound. There's a big difference, though, between routine ultrasound, which many people have had, and specialty ultrasounds, which we do here at UCLA. It's important because many patients with a history of endometriosis have been told they had a normal or negative ultrasound and therefore couldn't have endometriosis, and we just know that that's not true. Superficial implants of endometriosis on the peritoneum often are not able to be seen on an ultrasound at all, even with a specialty protocol. Ovarian endometriomas typically can be seen on any. We're really good at seeing cysts on ultrasounds of any kind. But deeply infiltrating endometriosis typically is not seen unless we're working through a specialty protocol. And we check something called a sliding sign. This illustration shows that. What you see here is this purple area is the probe of the ultrasound itself inside the vagina. The uterus is here in gray. The bowel is here in green. This lime green color, or maybe yellow, might look on your screen, is representing adhesions or scar tissue that are between these two organs that's not supposed to be there. And so in clinic, I describe it like this. This is your uterus, and your tubes and ovaries, and your bowel is underneath it. That probe goes inside the vagina. As we push up, the uterus should slide across the rectum. But if we push up, as you see here, and the uterus and the bowel move together, we know there's scar tissue here that's adhering these organs together in a way that they're not supposed to be. And that's not something that we should be surprised about at the time of surgery. And that way we can prepare appropriately and have the right team available to do that work. MRI is also used in endometriosis, and sometimes it gives us a better view, especially of these deep infiltrating lesions that may not be always perfectly seen with ultrasound. Treatment itself is the great debate within specialty circles of people who do endometriosis. Talking about medical management, it's important from my perspective to acknowledge that medical management is suppression of disease, not cure of disease. First line for medical management is generally birth control pills. Progestin IUDs are also very effective, and then there are other medications called GnRH agonists and antagonists. The GnRH agonists and antagonists are medications that work at the brain level to cause downregulation of the female hormones estrogen and progesterone. In any case with medical management, the goals are to inhibit ovulation and hopefully cause atrophy or regression of lesions that are already there, or suppress the new growth or implantation of lesions that may grow in the future. This inhibits and blocks hormones to do that. But these medications often come with side effects. Some patients have breakthrough bleeding, so if they try to skip their cycle with their pills, which is safe to do, sometimes they have a breakthrough period, and that can be very bothersome. Some patients on any kind of hormonal management will have hair loss or nausea, mood changes or weight gain, hot flushes, and if you're on some of these medications for a very long time, greater than 5 years, there might be decreased bone density. Endometriosis surgery is the other thing that should always be considered, especially if someone's tried medical management and has had either limited or short-term or no improvement in their symptoms. Diagnostic laparoscopy is generally speaking about when we put a camera in through the belly button most of the time to just look. This on its own is really pretty limited in its utility. We just look and then what? On its own, it doesn't really help with pain and it doesn't remove any disease. And so if you're with a doctor who says, well, I'll take you for diagnostic laparoscopy, but they maybe aren't comfortable dealing with that disease if they find it, at the very least, request that they document what they find with photographs that can be shared with you and then brought to a specialist who can take care of you afterward. And at a minimum, at least biopsy the tissue so that we have a diagnosis and we know for sure that that's what you're dealing with. Ablation versus excision is the next debate when we discuss endometriosis surgery. Ablation is where we use electrocautery to burn these areas of endometriosis, but it's really only for disease that's superficial on the peritoneum itself. If you think about an endometriosis implant kind of like an iceberg, the problem is you never know how deep the lesion goes. And this ablation technique really only burns the top layer. And so if that goes deeper than 5 millimeters, it's not going to burn everything. Additionally, if that lesion is overlying an area like the ureter, which is that tube connecting the kidney to the bladder, then burning the lesion could also burn the ureter, which could cause an injury and a complication. So we want to avoid that because we have thermal spread that can affect surrounding anatomy. Excision ultimately is where we cut the lesion completely out. We know the whole iceberg has been removed from top to bottom. And so then the discussion is that complete, incomplete, or radically performed? Outcomes from endometriosis surgery show mixed data as far as pain scores go, ablation versus excision of disease. We know through research that excision decreases those pro-inflammatory cytokines, again, those signals telling your brain that you feel pain. Excision surgery is correlated to decreased pain at 6 and 12 months postoperatively. Also, excision is shown to be superior to diagnostic laparoscopy even when medical management is added to it by itself. With good excision surgery, recurrence of symptoms at 1 year is about 10%, so it's pretty low. We feel pretty good about that. But at 5 to 7 years, the recurrence of symptoms could be up to 40 to 50%. Within endometriosis surgery then, we talk about conservative or definitive surgery. Conservative surgery is excision of lesions, excision of cysts, and this is done for fertility sparing. So in patients who are still wanting to plan a family, this is definitely the way that we go. Sometimes we have to think about maybe less is more. Again, you can have diminished ovarian reserve because of a cystectomy of an endometrioma. And so there's some workup that we need to do ahead of time before we make those decisions. Definitive surgery is more radical, and in these instances it could include a bowel resection if there is area of the bowel that's affected by endometriosis, but also hysterectomy or bilateral oophorectomy, often called a BSO. The rates of recurrence versus surgical menopause have to be weighed though. So if I take both of the ovaries out of a patient, regardless of her age, she experiences surgical menopause immediately. And so we have to weigh what's the risk of recurrence of the endometriosis versus what are the risks of this person being in menopause prematurely. She can have increased risk of heart disease and also increased risk of osteoporosis. Ultimately, the thing we want to know is what's the rate of reoperation, because that might give us an indication of how good of control a patient experienced. There's a study that looked at this question, and what they saw was that at 2, 5, and 7 years postoperatively, patients who had hysterectomy only experienced reoperation at 4, 13, and 23% at those year intervals, respectively. But patients who had undergone a hysterectomy with a BSO, removing the ovaries, experienced reoperation at 4, 8, and 8%. And so the risk is almost 2.5 times higher if you preserve or conserve the ovaries. But then that prompted another question. They did a subgroup analysis looking at women who were under 40, at 40 or under 40. And so they looked at patients who had excision of endometriosis plus a hysterectomy versus those who had a hysterectomy, excision of endometriosis, and the BSO removing both of the ovaries. And what they saw instead was the same risk of reoperation at the 7-year mark. And so the take-home message for that is for patients who are at or under 40, if the ovaries themselves look normal, they should keep them both. In the end, we take an individualized approach to endometriosis management. The right approach requires a multidisciplinary team of endometriosis specialists, colorectal surgeons, urologic surgeons, physical therapists, gastroenterologists. We have to individualize a plan to a patient's symptoms, their own needs, and also what their goals are. They go through diagnostic workup and imaging, and then it's a combination of medical and surgical management, often also physical therapy, because this chronic insult creates muscular problems that are not cured by medical or surgical management. But doing this gets a patient to a hopeful outcome where they can live a much better quality of life. These are some references if you decide you would like to do any more deep reading. And this is the number you can call for more information. This is the number for our clinic and the website where you can find myself and other endometriosis specialists who are here at UCLA. Thank you so much for joining us today for this talk.